Well, welcome everyone. Thank you for tuning in. My name is Dr. Anthony Esposito, and I'm an assistant professor at Northwestern University. I'm very proud to be joined by a panel of very esteemed colleagues who will be helping me present some very important guidelines that just came out in combination between the American College of Rheumatology as well as the American College of Chest Physicians, also known as CHEST. These guidelines were released as the first of their kind that focus on screening, monitoring, and treatment for what we have now deemed systemic autoimmune rheumatic diseases, otherwise known as SARDs. But we're going to focus today just on the treatment aspect of these guidelines. And note, at the time that we recorded this, this was not currently published yet. The executive summary was given at the conference at ACR last fall, and we do expect it to be published by the time that this is released onto our website. So the title of our talk today, our panel discussion, is a review of ACR CHEST clinical practice guidelines on treatment of ILD with systemic autoimmune rheumatic diseases. I want to thank CHEST for helping us put this together, and this webinar is presented as a part of the Diffuse Lung Disease and Lung Transplant Network. As I mentioned, I have quite a few panelists joining me today, and I'm very happy to have their expertise to kind of help guide us through these guidelines and thoughts on how they were formed and how they may change our practice. Starting with myself, as I mentioned, my name is Dr. Anthony Esposito. I'm an assistant professor of medicine in the Division of Pulmonary and Critical Care at Northwestern University Feinberg School of Medicine. I'm also the director of the scientific and translational research for our interstitial lung disease program. My clinical and research interests are centered on interstitial lung disease associated with what we call SARDs, particularly scleroderma and idiopathic inflammatory myopathies. And I'm specifically interested in early detection of disease and identification of biomarkers that predict response to therapy. I'm very proud to have as my co-chair for this session, Dr. Teja Kulkarni, who is an associate professor of medicine in the Division of Pulmonary, Allergy, and Critical Care Medicine at the University of Alabama at Birmingham Prestige School of Medicine. And she's also the director of UAB's Interstitial Lung Disease Program. Dr. Kulkarni serves as the chair of the Interstitial Lung Disease section of the Diffuse Lung Disease and Lung Transplant Network of CHEST. And she also serves as the principal or co-investigator on numerous clinical trials studying new therapeutics for ILD and developing imaging and molecular biomarkers to prognosticate and assess response to therapy among these patients. Again, I'm honored to have her as our co-chair for the session. Our next panelist is deemed our subject matter expert for her involvement in these guidelines, which she will elaborate on. But her name is Dr. Elena Bernstein, who is the Florence and Irving Associate Professor of Medicine in the Division of Rheumatology at Columbia University Maggiano's College of Physicians and Surgeons, and also the director of the Columbia University Scleroderma Program. Dr. Bernstein's research focus is on lung disease and systemic sclerosis, post-lung transplant outcomes of adults with systemic autoimmune rheumatic diseases, and the relationship between autoimmune and interstitial lung disease. Dr. Bernstein has received grants from the National Institutes of Health, Department of Defense, Rheumatology Research Foundation, and Arthritis Foundation to study lung diseases and systemic sclerosis. And as I alluded to, she was instrumental in developing these guidelines, which she will talk about in her session. Our faculty discussants include Dr. Sonia Danoff, who is a professor of medicine in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University School of Medicine. She also serves as the director of the ILD and the Pulmonary Fibrosis Program and associate director of the Myositis Center at Johns Hopkins. Dr. Danoff's research focuses on basic and translational studies of lung fibrosis with a particular focus on idiopathic inflammatory myopathies. She's been a recipient of numerous grants from the National Institutes of Health, American Health Association, and also the American Lung Association. And last but not least, we have Dr. Kristen Hyland, who is the director of the Rheumatic Lung Disease Program, and also the vice chair of the Integrated Hospital Care Institute at the Cleveland Clinic Foundation. She is a dual threat in that she's completed 2 fellowships in pulmonary and critical care medicine, as well as rheumatology. Dr. Hyland's clinical and research interests focus on the pulmonary manifestations of rheumatologic disease, with a particular interest in interstitial lung disease and pulmonary hypertension in the setting of scleroderma. He's a member of the Scientific Advisory Council for the Pulmonary Hypertension Association and the Scleroderma Foundation. We're honored to have her contribute her expertise to our faculty panel today and to give us insight from both the rheumatologic and the pulmonary aspect. And so this is a very long list of disclosures that I'm not going to go through, but I do want to point out two important conflict of interest. Dr. Bernstein, as I mentioned, was a member of the core team for the development of these guidelines, and Dr. Danoff was also a member of the steering committee for these clinical practice guidelines. All other disclosures mentioned here are unrelated to the guidelines. So our objectives today, our goal is to educate the chest community about these new ACR chest guidelines for the treatment of SARD-ILD and to discuss their impact on clinical practice. Our hope is that by the end of this webinar, participants who are tuning in with us will be able to apply guideline-directed treatment strategies for patients with SARD-ILD, and then also to discuss the implications of these guidelines on their clinical practice. To do this, we will have 3 faculty presentations, which they will introduce themselves, but it'll go through the development of the guidelines, first-line therapies for the guidelines, and then what to do when a patient has progressed past first-line therapy. After these have been presented, we will move on and have a panel discussion of what these mean for clinical practice moving forward. And with that, I will pause, and first we will start with Dr. Bernstein.
So thank you, Anthony, for that kind introduction, and thank you to Chest, to Tasia and Anthony for the kind invitation to speak today. Here are my disclosures. And basically, during today's presentation, I'll review the ACR chest ILD guideline development process. Now, the development of the ACR chest ILD guidelines was truly a massive undertaking. 2 guideline summaries are currently available online, and 3 manuscripts have been accepted for publication. 1 about screening and monitoring, 1 about treatment, and 1 about the patient panel. We anticipate publication by spring of 2024, so very soon, in arthritis and rheumatology and arthritis care and research. So we all know that interstitial lung disease is a significant cause of morbidity and mortality in people with systemic autoimmune rheumatic diseases, or SARDs. People with systemic sclerosis, rheumatoid arthritis, idiopathic inflammatory myopathies, mixed connective tissue disease, and Sjogren's disease are at greatest risk of developing ILD. Thus, there's a critical need for guidelines to help inform ILD screening, monitoring, and treatment in people with SARDs. Our objectives were to develop evidence-based clinical practice guidelines for clinicians who care for people with SARDs who are at risk for or have been diagnosed with ILD. Aim 1 was to develop recommendations regarding screening strategies for ILD in people with SARDs. Aim 2 was to develop recommendations for the monitoring of SARD-ILD, and Aim 3 was to develop treatment recommendations for SARD-ILD. Our core team included 6 rheumatologists, 1 pulmonologist, Dr. Danoff, who joins us today, 1 thoracic radiologist, 1 grade expert, and 2 literature review experts. Our literature review team included 13 rheumatologists, 8 pulmonologists, and 3 methodologists. Our patient panel was comprised of 21 people with SARDs. 19% were at risk for ILD, and 81% had been diagnosed with ILD. 71% were women, the median age was 53 years, 67% self-identified as white, 33% as Black or multiracial, and 10% as Hispanic. The patient panel met virtually with 3 core team members and 2 ACR staff. They reviewed the evidence report and provided their values and preferences regarding screening, monitoring, and treatment of SARD-ILD. Our voting panel was comprised of 13 rheumatologists, including 2 from the community, 10 pulmonologists, including 3 from the community, 1 radiologist, and 3 patient representatives from the patient panel. The core team developed clinically relevant population intervention comparator and outcomes, or PICO questions. A systematic literature review was performed. The literature review team rated available evidence using the grading of recommendations, assessment, development, and evaluation, or GRADE methodology. A patient panel was convened to share their values and preferences. and the voting panel achieved consensus on direction and strength of each recommendation. 70% agreement on direction and strength was required to achieve consensus. We started the process with 4,246 PICO questions. After we reduced the scope of the guidelines, we were left with 241 PICO questions, which is still a lot of questions to answer. So to put this in perspective, some guidelines answer only 10 or 15 PICO questions. Hence, this was really a massive undertaking. Now, the certainty of evidence was evaluated for each outcome using the grade system, which assigns one of 4 grades reflecting the level of confidence in the effect estimate: high, moderate, low, or very low. Well-designed, large randomized controlled trials start at high-quality evidence, while observational studies start at low quality. There are 5 factors that downgrade the certainty of evidence: risk of bias, inconsistency of results, indirectness of evidence, imprecision, and publication bias. For example, when assessing surrogate outcomes such as FVC, the certainty of evidence was reduced by 1 or 2 levels to account for indirectness. So a well-designed, large randomized controlled trial that used FVC as a primary outcome would have at most low-quality evidence. Now, I just want to conclude with a few points about SARD-ILD trials. In the global world of clinical trials, SARD-ILD clinical trials are relatively small. Census was the largest SARD-ILD trial with 576 participants, but this is a relatively small number when compared to the cardiovascular trials. Jupiter enrolled over 17,000 participants, and Pantos enrolled over 10,000. Even in the RA space, OnTract enrolled over 3,000 participants, while oral surveillance enrolled over 4,000. Moreover, the primary outcome in SARD-ILD clinical trials is usually FVC, which is a surrogate outcome. Surrogate outcomes are one step removed from what patients care about. They care about living longer and how they feel and function. The consequence is that even in a well-designed SARD-ILD clinical trial, the certainty of evidence can be low or very low. So I will stop there, and I want to thank everyone who was involved in this guideline effort, and I'm happy to answer questions later in the panel discussion.
Okay, thank you very much, Dr. Bernstein. Next, we have Dr. Hyland, who's going to present to us the guidelines regarding first-line therapies for SARD-ILD. Thank you, Dr. Hyland.
I'm Kristen Hyland, and I'm going to be talking about first-line therapies for SARD-associated interstitial lung disease. So I have several disclosures. You saw my industry-related disclosures on a previous slide. I'd also like to mention that all medications I discuss should be considered off-label for SARD-associated ILD with the following exceptions. Nintedanib is approved for scleroderma-associated interstitial lung disease and progressive fibrosing interstitial lung disease, and tocilizumab is approved for scleroderma-associated interstitial lung disease. I also like to emphasize, if you just heard, that other than scleroderma, well-powered clinical trials are lacking for SARD-associated interstitial lung disease. Results appear to be etiology-specific and not translatable across all SARDs. Extrapolating results from idiopathic pulmonary fibrosis to SARD-ILD is not advisable. And clinical trials are ongoing and need patience. And lastly, it may not be possible to treat pulmonary and extrapulmonary manifestations of SARD with a single agent. So these guidelines are in press, and I was not part of this guideline committee. So this is some, my expert opinion, if you will. So we just heard how frequent interstitial lung disease is in our systemic rheumatologic conditions. In fact, connective tissue diseases, when it was called CTD, makes up at least 13% of the world of interstitial lung disease. And you can see the interstitial lung disease is most prevalent in scleroderma, followed by mixed connective tissue disease, and then the idiopathic inflammatory myopathies, and then rheumatoid arthritis. And so naturally, most of our data comes from scleroderma because that's where we see interstitial lung disease the most common. Here you can see that connective tissue diseases vary in prognosis and in comparison to idiopathic pulmonary fibrosis. So are diseases that are more likely to have an NSIP pattern, such as your patient with scleroderma, have a much better prognosis than patients such as your rheumatoid arthritis patient that has a usual interstitial pneumonia pattern and looks and behaves a lot like the idiopathic pulmonary fibrosis patient. When we think about treating SARD-associated interstitial lung disease, we think about the pathogenesis. Tissue injury could be from gastroesophageal reflux or other oxidative stresses or environmental stimuli. There's a vascular injury component as well as autoimmunity and inflammation, and then, of course, fibrosis. So our strategies to treat SARD-associated interstitial lung disease are generally targeting all of these pathways. So importantly, we have to figure out which of these patients should be treated. When you do imaging, for instance, in patients with rheumatoid arthritis, you can see evidence of at least a little bit of interstitial lung disease in practically everybody. So one way to think about our patients is to think about those with extensive interstitial lung disease. And so from the Brompton, they categorize scleroderma patients into limited and extensive disease based on the extent of fibrosis. So if the extent of fibrosis is less than 10%, that patient has limited disease. Or if it's greater than 30%, that patient has extensive disease. If you're not so sure, it's somewhere between 10 and 30%, then you can look at forced vital capacity. If it's somewhat preserved, greater than 70%, that patient stays in the limited disease category. And patients with a reduced forced vital capacity then are categorized as extensive disease. So patients with limited disease have better prognosis. So one may wonder, are these patients that we could follow? Well, certainly, if your patient has risk factors for progression, which are different based on the type of SARD, or if they've already demonstrated evidence of progression, such as 10% decline in forced vital capacity or 5 to 9% decline in forced vital capacity, accompanied by a decline in diffusion, there may be a reason to also treat those patients. So this is figure 1 from the recommendations for the management of SARD-ILD in these guidelines that we're talking about. And so the first bit of recommendations I'm going to present is on scleroderma. And these include a strong recommendation against using glucocorticoids because this increases the risk of scleroderma renal crisis. So preferred first-line therapies for systemic sclerosis include mycophenolate, include tocilizumab, and include rituximab. Additional options could be cyclophosphamide, nintedanib, and azathioprine. So showing some of these data, oral cyclophosphamide was our first bit of hope in scleroderma. It was the subject matter of scleroderma lung study number 1. And you can see that more patients randomized to cyclophosphamide had a modest improvement in forced vital capacity compared to a modest reduction in forced vital capacity in those randomized to placebo. And there was a benefit in modified run and skin score. But when these patients were followed, so these patients were randomized to cyclophosphamide versus placebo for just 1 year, and then they were followed for an additional year. So if you look at forced vital capacity over time, you can see that there's a continued improvement up to 18 months. But by 24 months, where both placebo and cyclophosphamide were on no treatment for 1 year, any treatment benefit was lost. So we all know how toxic cyclophosphamide can be. And so this, now cyclophosphamide became, somewhat the standard of care, begging for the need for a more, or a less toxic agent. And so scleroderma lung study number 2 compared mycophenolate versus cyclophosphamide. And in this study, patients were randomized to either 2 years of mycophenolate versus 1 year of cyclophosphamide followed by placebo. And you can see that Although this was designed as a superiority study, thinking that patients on an extra year of mycophenolate would continue to have a treatment benefit versus the expectation that patients after a year of placebo following cyclophosphamide would lose all their treatment benefit. This study was actually a negative study in the fact that the cyclophosphamide and the mycophenolate arms performed similarly. Mycophenolate was better tolerated, but interestingly, patients randomized to the cyclophosphamide arm did not lose their treatment benefit at 24 months like the prior study. But after scleroderma lung study number 2, mycophenolate became the de facto standard of care for scleroderma-associated interstitial lung disease. So the FOCUS trial was a study looking at tocilizumab for skin disease in patients with diffuse systemic sclerosis who had a inflammatory phenotype. So they had significantly elevated modified Rodnan skin score, 10 to 35 units. They had elevated CRP or SARD rate or platelet count, and they were not on any background immunomodulator therapy. And they were randomized to tocilizumab, 162 milligrams subcutaneous weekly versus placebo, with primary endpoint at 48 weeks being change from baseline in skin score. The key secondary endpoints were change in percent predicted forced vital capacity, and other key endpoints included diffusion and HRCT fibrosis scores. So in regards to the primary endpoint, this was a negative study for the skin. But interestingly, there was a clinically and statistically significant difference in the key secondary endpoint, which was change from baseline in percent forced vital capacity at 48 weeks. And so these are data for the entire cohort of all patients. But there was, when you looked at baseline HRCTs, about 65% of those patients, even though they had very, very early disease, had evidence of interstitial lung disease. And you can see a more dramatic difference in forced vital capacity between the two treatment groups. In addition, there was improvement in fibrosis scores. And so given those data, tocilizumab became FDA approved for the treatment of scleroderma-associated interstitial lung disease. Rituximab has widely been used as sort of a salvage treatment for scleroderma-associated interstitial lung disease. This is based on limited data. In this systemic review, there was a 3.13% improvement in FVC percent predicted, and in very low quality evidence that rituximab can actually improve forced vital capacity in scleroderma-associated interstitial lung disease. Nevertheless, it is a treatment option for patients with scleroderma according to the guidelines with very low level of evidence. The census trial was the largest trial in scleroderma-associated interstitial lung disease, led to the first FDA-approved treatment for scleroderma ILD. The primary endpoint was annual rate of decline in forced vital capacity in milliliters per year, assessed at 52 weeks, with skin as a key secondary endpoint, as well as dyspnea by the St. George Respiratory Quotient. And so you can see that patients randomized to nintedanib had a less steep decline in forced vital capacity, with an absolute difference of 41 milliliters per year, representing a relative reduction of 44%. Patients were allowed to be on background mycophenolate, and about 50% of the population of the study was 580 patients. 50% of the population, mostly from the U.S., was on background mycophenolate. And in a subgroup analysis, patients on combination therapy numerically was better than patients on nintedanib alone, mycophenolate alone, or neither, with the caveat that this is a post hoc analysis and the study was not designed to tell the difference between these subgroups. However, these data give increased credibility to mycophenolate as a drug for scleroderma-associated interstitial lung disease. At the same time as the American College of Chest physician and the ACR guidelines for SARD, the American Thoracic Society published clinical practice guidelines for scleroderma-associated interstitial lung disease, saying strong in favor for mycophenolate, conditional in favor for cyclophosphamide, rituximab, tocilizumab, nintedanib, and nintedanib plus mycophenolate, with research recommendations for pirfenidone and pirfenidone plus mycophenolate due to levels of evidence in our publications. So now, what about the rest of these diseases? What data do we have? Well, we have data suggesting that steroids are beneficial in our idiopathic inflammatory myopathies with interstitial lung disease. And in this meta-analysis, you can see that either by fixed effects model or random effects model, that there is significant improvement in patients randomized to prednisone. So there's some data suggesting that prednisone can be useful. What about azathioprine as opposed to MMF? Well, in this study, a retrospective review of idiopathic inflammatory myopathy ILD patients, 66 were on azathioprine, 44 on MMF. There was an improvement in forced vital capacity, amounts of prednisone were decreased, but there was no difference in both agents, but there was no difference in forced vital capacity diffusion between azathioprine and MMF. There was slightly lower prednisone doses in azathioprine, but higher adverse effects in azathioprine compared to MMF. But at least we now have azathioprine as an alternative agent in patients that may need that. Rituximab versus cyclophosphamide was studied in the recital study, which was a double-blind, double-dummy randomized control phase 2b trial. And here you can see that both cyclophosphamide and rituximab resulted in improvement in forced vital capacity at week 24 weeks, with the difference between cyclophosphamide and rituximab of 40 milliliters. And here you can see the trajectories of change in forced vital capacity from baseline, which are similar between both agents. Rituximab was better tolerated than patients on cyclophosphamide. And in this meta-analysis, they looked at rituximab for rheumatoid arthritis-related interstitial lung disease. You can see how small these studies are. One study, 2 patients, another study, 5 patients. So really not a lot of data, but it seems like there may be a signal for a treatment benefit in forced vital capacity. And there's one in diffusion for patients with rheumatoid arthritis-associated interstitial lung disease. Definitely in all these trials, we are not seeing marked improvement in forced vital capacity. Well, the tacrolimus and cyclosporin are also agents that have been explored in myositis in this prospective multi-center open-label randomized phase 2 trial of 30 patients with tacrolimus and 28 with cyclosporin, 30% of which had MDA5, 60% of which had acute and subacute interstitial lung disease. There was really no significant difference between the two agents in regards to percent survival and progression. And then last kid on the block is tofacitinib for MDA5 myositis. This is a single center, open label, historical controls, all the caveats with that kind of study design where tocilizumab was used as a first-line agent in MDA5 ILD with a new diagnosis in 18 patients versus control. And then you can see survival. There seems to be a survival benefit in patients on tofacitinib, as well as an improvement in forced vital capacity. So taken together, I can say, first of all, the word of the day is conditional. All these recommendations, for the most part, are conditional recommendations that For people with SARD ILD, there's a conditional recommendation for glucocorticoids as first-line treatment, and they strongly recommend against glucocorticoids in patients with scleroderma because of the risk of sclerodermal renal crisis. Conditional recommendation for mycophenolate, azathioprine, rituximab, and cyclophosphamide as first-line ILD treatments for SARD ILD. For scleroderma and mixed connective tissue disease, conditional recommendation for tocilizumab. For patients with SARD ILD, there was a conditional recommendation against leflunomide, methotrexate, the TNFs, and abatacept as first-line treatments. In addition, for Sjogren's myositis mixed connective tissue disease, there was a conditional recommendation against nintedanib as first-line treatment for ILD. For scleroderma ILD, there was a conditional recommendation for nintedanib as first-line treatment. The panel could not agree on whether or not to use nintedanib as first-line ILD treatment option for rheumatoid arthritis-associated interstitial lung disease. For SARD ILD, they recommended against pirfenidone as first-line ILD treatment due to lack of evidence. For SARD ILD receiving mycophenolate, they recommended against adding nintedanib or pirfenidone to mycophenolate. For SARD ILD, there was a recommendation against upfront combination with nintedanib or pirfenidone with mycophenolate over mycophenolate alone. For myositis-associated interstitial lung disease, there was a conditional recommendation for JAK inhibitors as first-line treatment, but a recommendation against JAK inhibitors as first-line treatment for other SARD-associated interstitial lung diseases. For people with myositis, there was a conditional recommendation for calcineurin inhibitors as first-line treatment, but not for other forms of SARD-associated interstitial lung disease. There was a recommendation against IVIG or plasma exchange as first line for interstitial lung disease treatment options. And for people with SARD-associated ILD, there was a conditional recommendation for optimal medical management over referral for stem cell or lung transplant as first line for ILD treatment. And with that, I will end, and I'm happy to take questions at the end.
Thank you for that lovely talk, Dr. Hyland. Next, we will have Dr. Danoff.
Thank you to the organizers, particularly to CHEST for highlighting what I think is going to be a very important initial stab at trying to create a framework for treatment of interstitial lung disease in the context of systemic autoimmune rheumatic diseases. I'm going to take on the task of starting where you heard Dr. Hyland end, which is, what do you do if your patient continues to progress despite very reasonable initial therapy? And I'm going to talk both about the progressive case and also the rapidly progressive case. And so I'm just going to begin with disclosures. I was a core committee member. I was the pulmonologist on the core committee for this statement. And I think you've already seen the disclosures. And just as mentioned by Dr. Hyland, in my presentation, all of the medications I'm going to discuss are off-label, aside from those that she had mentioned in her introduction. So let me just kind of frame my talk by saying that what you've really heard so far is about the process. And you've heard from Dr. Bernstein that these guidelines use incredibly robust methodology. And what you've also heard from both Dr. Hyland and Dr. Bernstein is that nothing substitutes for high quality data. And unfortunately, these are relatively rare diseases. They're small populations. So we really do lack, to a large degree, the kind of high quality data you might see in some of the other clinical trials. And as a result of that, most of the statements that we're making are conditional rather than strong recommendations. And that's really because the strength of the evidence is lacking. And I think that what that also tells us is that these are areas where we really need to spend more time doing research, conducting large clinical trials to try to fill in that space. The other thing about these guidelines is that rather than focusing on a single disease type, we elected to try to cover a wide range of systemic autoimmune rheumatic diseases. And part of the rationale for that is that, often when you approach a patient like this, you may actually not at the beginning know exactly what type of autoimmune disease they have. And this way it would give people sort of a strategy or an approach. Finally, consensus was reached on some, but not all of the statements. And you heard a little bit from Dr. Hyland about some areas of disagreement. And I would say that the level of agreement diminished as we moved into the progressive and rapidly progressive diseases. And, we had a lot of very thoughtful discussions. And ultimately, sometimes we actually couldn't even agree on what we were disagreeing about. So you will hear that lack of certainty in some of the areas that I discussed. So with that, I want to start off by doing several things. I want to just make sure we're using a common definition for progression of SARD-ILD. I'm also going to distinguish that from rapid progression or RP-ILD. I'm going to talk about the treatment guidelines at a high level for both progressive and rapidly progressive. And then I'm just going to end by describing some of the limitations of the recommendations. And I think I've alluded to some of them already. So when we talk about progression, what we are saying is progression despite first-line ILD treatment. So as Dr. Hyland very nicely reviewed, we came up with a group of therapeutic agents that we thought a reasonable person could use as a first-line choice in treatment of a patient presenting with a SARD-ILD. The way we chose to define progression was to use the inbuilt trial criteria, which was essentially that we're discussing a patient where there's a drop in FVC of greater than or equal to 10% predicted, or between 5 and 10% with worsening respiratory symptoms, or increased extent of fibrosis, or worsening of respiratory symptoms and increased extent of fibrosis in the absence of an FVC decline. But the important piece is that this is occurring over a 24-month period. So this is a decline that we might see over 2 or 3 sets of pulmonary function tests or 2 or 3 clinic visits while we're monitoring response to therapy. Now, I want to contrast that to what we described as or defined as rapidly progressive ILD. And again, all of these definitions are essentially definitions of convenience. There's no absolute definition for any of these. But what we were really trying to focus on was a subpopulation of patients with ILD who had very rapid deterioration. And for example, from being able to be functional on room air or at their baseline oxygen requirement to very high levels of oxygen or even intubation within days to weeks. And that this occurs in the absence of an alternative cause like an infection or heart failure or thromboembolic disease. And we wanted to distinguish rapidly progressive ILD from progressive pulmonary fibrosis and to clarify that these are not interchangeable terms, so that we're really talking about a very distinct group of patients. So let's dive into the overall summary of this, of the results for progressive SARD-ILD. So again, just to remind you, these are patients or individuals who progress, have evidence of progression on first-line therapy. And all of these recommendations are either to add or switch therapy. So we could not agree that there would be either a choice of one, of either adding or switching, that both were very reasonable. So I want to just point out again, as you saw with Dr. Hyland's presentation, that this was done by narrowing down into subcategories of systemic autoimmune rheumatic diseases, because we recognize that there were going to be differences between the diseases. And just as she highlighted in her presentation, the data actually is different for some of the different diseases. So let's start at the bottom of this table. And just to highlight something that Dr. Hyland had already pointed out, which is in a patient with progressive disease, there was a recommendation against the use of long-term glucocorticoids. And I will emphasize long-term, meaning that we did not consider that using glucocorticoids as a maintenance agent at high level was going to be an appropriate choice, and that recommendation was strong if the patient's underlying disease was systemic sclerosis. There was also a general agreement that a patient who showed progression on a first-line agent was somebody where there needed to be thought about possible referral for lung transplantation evaluation, and that would be more appropriate for a patient where they had failed first-line therapy and you were already starting to think about adding on second-line therapy. So let's just discuss the recommendations for systemic sclerosis. And you heard very nicely from Dr. Hyland about the clinical trials that led to the identification of these choices of therapies. What I really want to focus on is you've heard about all of these therapies, and I want to just focus on the fact that hematopoietic stem cell transplant was one of the options that was considered in patients who had progressive disease. However, it was very strongly limited to centers that had experience with it. The data on this appears promising, but is available in a very limited number of centers. So that might be something to consider in a patient who has progression despite use of an appropriate first-line therapy. Now, when we got to myositis, there were a number of agents that were considered. You have heard about mycophenolate rituximab, the addition of calcineurin inhibitors, which has become increasingly used both in retrospective studies, as well as the addition of nintedanib as with the strength of the InBuild study showing a slower decline in patients who had progressive fibrosing disease in the context of appropriate initial therapy. The other thing that you'll see that has appeared here is IVIG. Again, the data for IVIG is relatively sparse. There are some series that have looked at it retrospectively as well as prospectively, but they're very small. And so this was added as principally a consensus agreement in terms of expert use. You'll also see the introduction of a JAK inhibitor, which again, as you've already heard, is only recommended in a very limited number of disease states. The next group to be considered are the mixed connective tissue diseases. And here what you'll see is that tocilizumab, which was also considered for systemic sclerosis, has been added back to the list. You'll notice that JAK inhibitors are not included with the mixed connective tissue disease. Regarding rheumatoid arthritis, again, you'll see the presence of tocilizumab as one of the options for second-line therapy. You'll also see the presence of pirfenidone. This was on the basis of a clinical trial which failed to meet its primary endpoints, but looked specifically at pirfenidone in RA-ILD and showed a decreased rate of decline of FVC in that patient population who are on pirfenidone. The last group is a group with Sjogren's. Again, you'll see a very similar group of therapeutic agents that are recommended. Now, I just want to make the point that we also really discussed whether there should be any kind of ranking of these choices. And the agreement was that because access to therapy can differ in many different places, that we did not want to rank these in terms of their which is preferred over others, but that we would leave it to the discretion of the individual treating physician along with joint decision-making with the patient to determine which would be most appropriate. Now, I want to go on to rapidly progressive ILD, and the starting point of this guideline evaluation was whether it makes sense in a patient with rapidly progressive ILD to consider monotherapy, that is one medication, or whether it is more reasonable to start with upfront dual therapy or triple therapy. And as you'll see, the agents that were considered for monotherapy are oral or IV glucocorticoids, mycophenolate, azathioprine, the calcineurin inhibitors, rituximab, and cyclophosphamide. Dual would be the use of glucocorticoids with one of the other agents. Triple would be glucocorticoid with two of the other agents. So in this schematic, what we really wrestled with is trying to separate out very rapid, typically disease associated with myopathies, including MDA5. And in those patients where we've recognized historically that there's an extremely high mortality rate, the consensus was that upfront triple therapy was actually appropriate, and that upfront triple therapy would include IV glucocorticoids as well as two additional therapies, and that was essentially the decision of the treating physicians. So it might include the addition of cyclophosphamide, IVIG, mycophenolate, a calcineurin inhibitor, JAK inhibitor, or rituximab. By comparison, we considered that there were some patients who presented to with rapid disease, but perhaps were less likely to have that very, very severe disease that might lead to admission to the ICU. And in that case, there was a sense that it might be reasonable, in addition to IV glucocorticoids, to only use one or two additional therapies. So the general categories of therapies are very similar, but the number of starting therapies is different. Now, I do want to make a comment about the fact that we did not separate out systemic sclerosis in this situation. There was a lot of discussion around whether the risk for scleroderma renal crisis essentially eliminated the use of glucocorticoids. But ultimately, the consensus was that because the potential risk was the death of a patient, that all therapeutic agents should be on the table for a patient who was in this very rapidly progressive category, regardless of what their underlying diagnosis was. And obviously, in this patient population, there was very strong urge for early lung transplant referral, as many of these patients have difficulty recovering or recovering to a good quality of lung function. So just to finish off, I want to mention that there are obviously many limitations to these guidelines, and particularly, I think, to the section that I discussed, which is step-up therapy or rapidly progressive ILD. We tried to cover a very broad and complex topic, which means that nobody was really satisfied with everything. We had very limited high-quality data to base these recommendations on, and so much of it was based on case series and expert opinions. And we all agreed that there are no first best choices for many situations. So in each of these situations, I would suggest that one has to use one's best judgment and joint decision-making with the patient. And with that, I'm happy to end. And again, thank you to the organizers for covering this very important topic.
Thank you all, Dr. Stianoff, Bernstein, and Highland, for those great presentations. And so with that, I'd like to lead us into a panel discussion where we can talk about a few questions that probably more often come up when we think about practically applying these guidelines into clinical practice. So I think my first question, I'd like to start off with the last limitation that Dr. Danoff had on our slide. There are many firsts that are recommended, but not the best choice. So, when we think about this, clinically, how do we, go about choosing your first agent, and what role does the specific underlying disease, extrapulmonary symptoms, and patient factors that you take into consideration to decide on the first-line therapy? And perhaps I'd like to start with Dr. Bernstein.
Sure, and it's a great question. So you can see that at least, for the
purposes of the guidelines, actually mycophenolate was sort of the first line treatment recommended across the board. So although we didn't rank, we didn't prescribe a hierarchy, but we do list the medications in the order that the voting panel preferred them. So the way the voting was done is that panelists would compare one drug versus a comparator. So A versus B, A versus C, B versus C, B versus D, et cetera, et cetera, et cetera. So MMF sort of won out, across all diseases. So generally speaking, I think, yes, mycophenolate is a reasonable first medication for many of our diseases. Now, some might say, well, why on earth would you give someone with RA-ILD mycophenolate? Because it's not going to do anything for their joints. And that, yes, that is a reasonable criticism. I want everyone to keep in mind that these guidelines, when they were made, we asked panelists to focus specifically on ILD. So these recommendations are specifically for the SARD ILD, not, for example, for synovitis associated with RA. Obviously, if someone is a rheumatologist seeing a patient in the clinic and that patient has, multiple different organ manifestations, that rheumatologist is probably going to want to pick a medication that targets more than just the lung. So, personally, I think it's very reasonable and to take into account someone's extrapulmonary manifestations of their disease. So if I have someone with RA-ILD, for example, and I want to use a medication that's going to potentially treat their ILD and other organ systems, especially joint, I'm probably not going to pick mycophenolate as my first choice. I'm probably going to think more about tocilizumab or rituximab, maybe even abatacept, which was, conditionally recommended against in these guidelines. So clinicians have to use their judgment.
There are also a lot of patient level factors. And, one of the things that we discussed is that, mycophenolate is not considered appropriate for pregnant women or women who want to have a pregnancy. And so in that situation, you would want to have the latitude to use a different medication like azathioprine. And so we really wanted to maintain that latitude for people to be able to have that individual patient level discussion rather than being more prescriptive and saying, oh, you have to do this and then you have to do this.
And that's a great point, because there were a lot of people, including some on the panel, who were like, why on earth is azathioprine on a list of first-line therapies for SSc-ILD? Now, granted, it's listed as an alternative, first-line agent, not a preferred. And the difference there is preferred agents are the ones who most clinicians would use in most patients most of the time, whereas additional, options would be used in certain circumstances. And pregnancy is that exact really circumstance. So if someone with SSc-ILD wants to try to conceive soon or already is pregnant, you're going to reach for azathioprine and not MMF.
As a follow-up to that, I actually have, there's a clear discrepancy. So Dr. Hyland showed our sister society, the American Thoracic Society, recommendations for scleroderma ILD treatment. And they had a strong recommendation for mycophenolate, whereas here was a conditional one. And I'm just curious what the thought process behind making this a conditional versus another society making it a strong recommendation for scleroderma specifically.
Yeah, so both, and Dr. Hyland can correct me if I'm wrong, but I believe ATS also used grade methodology. It is in how different societies probably interpret grade. So, you can make a strong recommendation in the absence of high quality evidence if there's a life-threatening circumstance. We, in the sort of ACR chest guidelines, did not feel that this was a life-threatening. Yes, ILD can certainly be life-limiting, usually not in the immediate future. So that's why there was a conditional recommendation. Because again, if you referring back to one of my slides, looking at the fact that the largest trial in SSc-ILD, which was census, had 576 participants, and that's very few. So that's not a large. It was a well-designed trial, RCT, but it wasn't really large enough in the great grand scheme of clinical trials. And it also used FVC as a primary outcome, which is a surrogate outcome. So the level of evidence for all those reasons was really downgraded. And that's why the conditional recommendation in our ACR Trust ILD guidelines was given.
Great. I want to bring in corticosteroids as the first line of therapy. Obviously, when you think about all the long-term side effects, we don't want to use that as a long-term first-line therapy. But what are the clinical circumstances that all of you consider that as either like first-line therapy or just thinking about utilizing it as a bridge while we consider other first-line therapies, including MMF or tocilizumab or azathioprine? Perhaps Dr. Hyland.
Sure.
I guess your opinion.
I think corticosteroids work the quickest. And a lot of times our patients need some relief from suffering, whether that's their lungs, their joints, their skin, their muscle weakness, and our other immunosuppressive therapies take time to work. And so, patients need to be bridged to provide relief and to prevent progression. But I think the key is that we have to use steroids responsibly. They have significant toxicities. We have to remember, PJP prophylaxis. We have to protect bone health. We have to worry about glucose intolerance and, the issues with vision and everything else that corticosteroids can do. And so I think the more important message is that long-term corticosteroids should be avoided if at all possible, because cumulatively they're pretty bad news.
I just want to, on the one point that you brought up about PJP prophylaxis, oftentimes, I think at least in my experience here, I think it might be single center, but there's always a discrepancy in what pulmonologists have the threshold for PJP prophylaxis versus what I see from our rheumatology colleagues. I think we have a pretty balanced panel here. So what are your thoughts on that?
I think we need another guideline. That's the next guideline. I've looked at this in a lot of depth in connective tissue diseases, and there really is not good guidance. There seems to be certainly stronger recommendations in vasculitis. There's stronger recommendations in myositis in patients who are lymphopenic. But in patients who are on immunosuppressive therapies and corticosteroids over a certain threshold, 20 milligrams is the one most commonly I see. So I think, there are scenarios where we should at least think about it, but I think we all, at least the pulmonologists, see enough PJP come across our path that it's better to err on the side of being conservative.
I think that's especially true given the underlying lung disease. Patient who is relatively stable who gets PJP, it can be a life and death situation, and it's an entirely preventable disorder. And so, I think that we all feel fairly strongly that we want to essentially have zero episodes of PJP. I think the thing that surprised me is, particularly when we have patients who are on multiple agents, which is very, very common in our SARD ILD patients, is that even below 20 milligrams of prednisone, we sometimes see patients where if you check a CD4 count, their CD4 count is way below 200. And so that's been very much a cautionary tale to me. And again, I don't have the answer to it, but I agree with Dr. Hyland that it is something that we need to look at in a more systematic fashion.
Great discussion. I do think we need another guideline, Dr. Hyland, because I'm not quite sure when to start and stop it. And when you're using combination therapy, it's hard to make that decision, right? Speaking of hard decisions, this is something that I struggle a lot with in my nascent practice. So I'm curious how the panel approaches a patient like this. So moving on to kind of the progressive disease that Dr. Danoff talked about. When you have a patient with progressive disease, how do you decide whether to go the immunosuppressive route or to go the antifibrotic route. And then when do you know when to stop the immunosuppression and when to start the antifibrotic? Kind of the holy grail, but I'm curious on how everyone practices.
I can start. So you might get different answers from rheumatologists versus pulmonologists. But, at the core, these are all autoimmune diseases. And so the backbone of therapy, many people would say, is immunosuppressive therapy. Typically, obviously it's case by case, but typically if someone is progressing, I will add a second immunosuppressive. I'm a fan of adding rather than switching for synergy. I would say the exception there is if someone has more of a UIP pattern, more of a fibrotic pattern, then that would be a time when I would think more about, nintedanib than an immunosuppressive. But for me, it's rare that I would use an antifibrotic as sort of the second medication in someone who is progressing. For me, it's going to be the third or fourth, ILD aside. And when to stop immunosuppressants, I don't stop them unless there's, intolerance, some sort of side effect that requires stopping them. I don't see a reason to stop them.
Would you factor in like a CT pattern, or again, bringing in the extrapulmonary symptoms in making that decision? Like, say, for example, if I see a lot of ground glass that has progressed on the CT scan versus more of a, fibrotic progression, and that's somewhere I start thinking about like whether, this is more fibrotic progression. Should I start with an antifibrotic therapy first and then, or still consider, additional immunosuppression or switching immunosuppression? Are those factors that were either discussed or, how you consider in your practice?
In my practice, I look at the CT pattern. If it's UIP, I'm probably a lot quicker to add antifibrotic than if it's not UIP. Ground glass can be a little trickier. We believe that is, quote unquote, alveolitis and potentially reversible, but it could be very fine fibrosis that we're misinterpreting. So you have to be careful there. I believe, even in scleroderma, we know fibrosis begets more fibrosis. There are these different pathways. They're all at play. There's a vascular pathway as well. So I think we can't be faulted for wanting to target multiple pathways in one disease. And so I am someone that, I am an adder as opposed to a switcher, but I tend to try to target multiple pathways when I'm treating someone.
And I think that the only two other things that I would add, and just to add on to what you've already heard, is that, often patients have more than lungs involved, and antifibrotics, at least to my understanding, do not fix other problems. And so you almost always, I think, have to add on if you add an antifibrotic, because you're going to otherwise have the potential to unleash some other component of it. And the other thing I think is really important is side effect profile. And that's, one of the things that we really spend a lot of time talking to our patients about is what does it mean if we're going to add on a drug that has a substantial and potentially different side effect profile from other medications that they're taking. So again, I really think that a lot of this is joint decision making with the patient, with a lot of kind of clarity around what the goals are. This drug is being added to slow your rate of decline, and we do not expect that this is going to improve your lung function. So really very granular discussion about those things.
Yes, I absolutely agree. I think there are so many patient factors that come into play. I mean, it's great to see the guidelines with all the medications listed, but then when we actually think about clinical practice, there's so much more into that decision making.
We need bigger studies. We need studies in non-scleroderma. We need to replicate scleroderma lung studies in our other rheumatologic diseases to help inform those decisions.
Absolutely.
I had one other question about the use of cyclophosphamide. And particularly, I think somewhere down in the asterisks of the guidelines, it mentioned that cyclophosphamide is not usually used in combination with other agents for progressive disease, but then it lists it as a combination agent for RP-ILD. And so I'm just curious, in practice, and then with the data that we have where there is a lot of non-inferiority with other agents, when would we be using cyclophosphamide for our patients?
Yeah, I think that, again, this is very context dependent and also it's practice dependent. So, the concerns around cyclophosphamide are, firstly, it's got a lot of both short-term and long-term toxicity. You can only use it for a limited period of time. If you're treating younger patients, you can lead to infertility. So if you want to use it in a younger patient, they need to plan if they want to have children to bank sperm or, store eggs. And so it's got a lot of toxicities around it. On the other hand, if you have limited choices and a patient is rapidly progressing towards death, then you take whatever you can get in your hand. I have to say that we in our institution are using a lot less cyclophosphamide, especially in ICU level patients, just because of the concerns of infection in patients who get cyclophosphamide, particularly in IV dosing, where they will often have sort of a nadir white count, and it puts them at fairly high risk of infection, at least in our experience. So we're actually using less of that and using more of IVIG. But I think that, every institution uses what they have and what they feel comfortable with. And so I do see it as being something that when you have to slam the brakes on really hard, that is one of the agents that really can accomplish that endpoint.
I borrow, I used a lot of cyclophosphamide and scleroderma in the early days. And I use some of my cyclophosphamide philosophy I steal from the vasculitis folks as well, where, they use it for, man-eating vasculitis, but they use it sort of in induction manner where, a few doses and then, with the intent to switch to something else as quickly as possible. And so, I'll pull it out for, really, when I have to slam on the brakes, as Dr. Danoff says, when, the patient is super ill, I'll pull it out with the intent that I'm going to mitigate as many side effects as possible by limiting the duration as to, 3 months if I can, or less while I get other agents on board.
Okay. Well, that was a wonderful discussion, everyone. I really appreciate everyone's time. I'm just going to switch over here to kind of wrap up our session. So thank you to all the panelists who participated today. You've met every single one of them, and your input was very enlightening, and hearing how other people practice and how we choose agents has helped me, and I'm sure many people that are watching this through our website. Also want to thank, obviously, CHEST, the Diffuse Lung Disease and Lung Transplant Network, and the Interstitial Lung Disease section who sponsored this. And importantly, I want to also thank the CHEST administration, importantly, Beth Corey, Michelle Kosabuki, and Matteo Valia, who helped us with making this webinar. If you have any questions for any of the panelists, feel free to email me or Dr. Kulkarni. We will send the questions to where they need to be. And I hope you enjoyed the session. Thank you, everyone, for attending.